Hi, I'm Heather Harper, and this is my verbal presentation for assignment number 1, the SOAP note. The demographics for my patient for the SOAP note are going to be JD, 40-year-old male with the acute abdomen case. So the chief complaint is a 2-day history of increasing abdominal pain. So JD is a 40-year-old male who presents with new onset abdominal pain, which started 2 days prior to visit after eating a cheeseburger dinner. The pain started as a sharp stabbing pain lasting about 1 to 2 hours and progressed to a steady, persistent pain. He rated 7 out of 10 with a bit of a waxing and waning pattern. This is the first occurrence of this type of pain for JD. He's been able to lie still or sleep with the pain, denies any radiation to his back or his flank, and didn't find any relief taking 1,000 milligrams of Tylenol. The pain does seem to be worse with deep breathing. He reports a loss of appetite and has not eaten anything in the past 2 days. Last bowel movement was today and denies melena or hematochezia. He's been febrile with a Tmax of 38.2, chills, intermittent nausea, and has vomited once today while at home. Generally speaking, his general health status is good. He doesn't take any prescription medications. He doesn't have any drug allergies, although does have an allergic dermatitis, which was diagnosed by an allergist. It's likely to laundry detergent. Unfortunately, he has no family physician, denies a seasonal flu shot, and can't actually remember the last time that he was seen in a medical office. Currently, his height is 177 centimeters, weight is 93 kilos, has a BMI of 29.4. Immunizations are all up to date. So medical history is quite unremarkable. No chronic health conditions, no surgical history to report. Patient denies any mental health concerns past or present, although he does admit to having an occasional low mood. Family history is remarkable for he's being adopted, doesn't know his biologic parents or their medical history, doesn't have any biologic or adopted siblings, has a close relationship with his biologic or adopted parents, although they live in another city. His social history is remarkable for the fact that he's unmarried and lives alone. Works shift work as a security guard, so does spend a lot of time in a car, sort of sedentary, driving around. Did 2 years of college, finished 2 years of a program, but it didn't complete. He does admit to have quite irregular eating patterns due to his work. Rarely cooks at home and does eat fast food frequently. He gets little exercise due to the sedentary nature of his job. He does drink occasionally, 1 to 2 drinks per day. He says he uses alcohol sometimes to get to sleep, is a non-smoker of cigarettes, marijuana, and denies any illicit drug use. So we did a focused exam, physical exam today. Vital signs were heart rate of 114, blood pressure was 148 on 95, respiratory rate of 22, oxygen was 97% on room air, and a temperature of 38.3. On exam, initially I noted him to be in moderate distress, grimacing and having difficulty remaining sitting still or lying on the exam table. We did a cardiovascular exam due to his tachycardia. Skin was clammy and pale, extremities a little bit cool to touch. There were no abnormal lesions or ulcers on any of his skin or any extremities. His pulses were all symmetric and equal with a +2. No edema noted. Cap refill normal at less than 2 seconds. Inguinal lymph node exam was unremarkable. He was tachycardic, again, as mentioned, at 114. S1 and S2 heard. No abnormal sounds, no murmur, no rubs, no gallops, no palpable thrills, no displacement of his PMI. Abdominal bruit wasn't examined because of the pain he was having with his mid-epigastric area. Respiratory exam was remarkable for pain with deep breathing, although his auscultation of his lungs was clear on all fields, although breath sounds were a bit quiet, no crackles, rhonchi, or wheezes. Normal chest expansion, normal tactile firmitis noted on his anterior and posterior lung fields, Voice transmission tests were normal, and his respiratory effort was normal with no use of accessory muscles. On his abdominal exam, visual inspection, I did note his abdomen was a bit round and a bit distended. No obvious skin issues, herniations, bulges, lesions, or rashes. On listening to his abdomen, his bowel sounds were quite hypoactive on all 4 quadrants. No buoys heard, no venous hum or friction rub heard over his liver or spleen. Percussion of his abdomen didn't reveal any dullness or tympany. Liver size appeared to be normal, although the measurement was difficult due to the pain in his abdomen. No splenomegaly was noted. Palpation of the abdomen was normal over the left side, left upper and lower quadrants, although he was guarding with palpation on his entire exam, and there was rebound tenderness on his right upper quadrant, and he did have a positive Murphy sign. Again, the aortic assessment was deferred due to his discomfort. So to summarize, we have a generally healthy 40-year-old male who came in with sudden onset right upper quadrant and mid-epigastric pain that had started 2 days prior after a high-fat meal. The pain has persisted, is now accompanied by nausea, vomiting, fever, tachycardia, and a positive Murphy sign. And that concludes my verbal presentation of my SOAP note. Thank you very much.